CMI was reduced and BCG was effective in treating. Now this is the second case where a 44 years man is presented with borderline leprosy. His skin smear, initial skin smear showed bacillary index of 2+ and morphological index 0. So this is borderline, so it is midway between just going to multibacillary type from possibacillary type. So morphological index is 0, but bacillary load is high, bacillary index is 2+. So as it was a case of borderline leprosy, he was started with multi-drug therapy. And the reactions, the lesions were improving. The punched out inverted fossa leg lesions, they get flattened, and the symptoms also improved. The patient, the erythema gradually faded, and the color was coming to normal. But after 8 months of multi-drug therapy, there was a type 1 reaction. The type 1 reaction is that the affected area, those become shiny, there is scaling, and there is a malaise fever-like thing. There may be regional lymphadenopathy also. All of a sudden, the patients were getting better and better, but all of a sudden, it seems that the lesions are worsened, the patient become having fever, malaise. Patient gets very apprehensive that medicine is not working properly or the medicine is causing some damage. So again he was sent to School of Tropical Medicine, and they did repeat skin smear. It came to a bacillary index of 4+ and morphological index 0. Morphological index was 0, but because that was the case of HI and he was treated with MPT, but bacillary index became 4+ from 2+. So as this was the case of type 1 reaction, and type 1 reaction has to be treated with steroid and clofazimine or clofazimine. In type 2 we treat with thalidomide, but type 1 there is a immense role of steroid. So we had to give steroid. So before giving steroid, to assess his immune status, Mantoux test was done. Maybe at that point of time they thought that they will treat with BCG. So that is why they advised Mantoux test. We did Mantoux here, and we had seen that there is no response. We again sent the patient to School of Tropical Medicine. They started as with steroid, but because reaction had to be treated with steroid, otherwise there will be sudden neuritis or that may cause sudden foot drop, wrist drop, etc. That will contribute to such morbidity, irreversible morbidity. That is why that steroid was started, but they reinforced the treatment with monthly ROM. This is another mode of giving ROM therapy, rifampicin, ofloxacin and minocycline. It is given every month so that resistant or persistent mycobacteria, these are killed by these rifampicin, ofloxacin and minocycline because these are highly bactericidal in case of Mycobacterium leprae. But along with that, MDT was multi-drug therapy with usual dapsone, clofazimine and rifampicin monthly was continued. So this was the lesion improved actually, but all of a sudden that border got elevated, there was scaling, that some area looked erythematous. Actually that patient also didn't tell initially because he had a long back, he had a fracture for which he was operated, and it was just above that area. So he had a feeling of some type of paresthesia around that scar. So he thought initially when the tingling, numbness, burning, etc. appeared, he didn't care much. When this skin lesion picture changed, then he came to us. But in spite of ROM and steroid, that reactions were repeating, and those reactions gradually become severe. The scaling was more, erythema becomes more. The lesions which had subsided, they presented with similar type of erythema and scaling. Patient was febrile every off and on. There were joint pain. So at that point of time, single dose of BCG was administered, thinking that it will boost his cell-mediated immunity and that will contribute to his treatment. After that BCG, the frequency and severity of the reactions got less, and the reactions ultimately stopped altogether. And after 3 weeks of that BCG, single dose BCG, there was a development of popular nodule at the injection site. So repeat skin smear was done after 3 months, when there was no reaction at all, and the skin lesions also become normal, subsided. It showed bacillus index 0, microbacterial index, morphological index 0. So and as the reactions had stopped, steroid gradually tapered off, and at that point of time again MANTU was repeated, that MANTU shown positivity. So then we assume that his CMI again has regained from previous what it was previously, and that patient is still on follow-up with us. It is 1 year follow-up, as it was a case of multi-drug therapy. We have given that multi-drug for complete. Instead of 12 months as the reaction occurred, we had given for 18 months, and now we have stopped the multi-drug therapy also. For last 3-4 months, we have told him to come every month, and there is no reaction, there is no recurrence, no sign of any active infection at present. So these are 2 difficult cases which we faced and which were treated with BCG. So we know that protective immunity against Mycobacterium leprae depends on cell-mediated immunity, and type 1 reaction is also dependent on cell-mediated immunity, because it is type 4 reaction. It is not antigen-antibody reaction. That is why when a serum of one person having this reaction will be transferred to another person, it will not be showing any reaction, because it takes time to develop. That is why the reaction appeared 8 months after initiation of multi-drug therapy. And in case of multivesicular leprosy, the high antigen load depresses the cell-mediated immunity. The patient's own cell-mediated immunity is depressed, and body fails to mount immune response against the leprae bacilli. That is manifested as there is no reaction, no papillary nodule at the BCG injection site, and MANTU being negative. It shows that cell-mediated immunity is depressed at that point of time, and that suppressed cell-mediated immunity it impairs bacilli elimination or killing of the bacilli. It becomes a vicious cycle. Gradually, that is why when the borderline patient, if not treated aggressively, they will gradually become borderline lepromatous, and after that they will turn into polar lepromatous. It will be very difficult to treat. So, and chemotherapy will seem ineffective. In spite of all the treatment, patient will downgrade. So at that time, we should try to boost his cell-mediated immunity. And it is also known that in multivesicular, polyvesicular leprosy, the CD4-CD8 count is altered. That multivesicularly, they have more T4 suppressor, CD8 plus the T suppressor cells. It is CD4-CD8 ratio is CD8 is 1, CD4 is, for every CD4 it is 0.6. In case of polyvesicularly, the CD4-CD8 is, CD4 is more and CD8 is less. The helper is more, suppressor is less. But here that suppressor is more, helper is less. That is why in case of polyvesicular leprosy, even if we do not treat, some of them they will get treated of their own. The single patch, 2 patch leprosy, these will get treated of their own. There was people who advocated single ROM therapy for less than 5 patches of leprosy. Polyvesicular leprosy, give a single dose of ROM, that will take care of that infection. But in case of multivesicular leprosy, as the suppressor cells are more, the helper cells are less, there is reduced cell-mediated immunity, even the best available treatment seems ineffective. That in those cases, BCG stimulates host immunity by inducing CD4 plus cells, that helper cells are increased. So these are the, I thought these are the new treatment methods which is being practiced in many centers who treats with leprosy. So this is one way of using an old vaccine which is available in almost all the hospitals to treat the difficult to treat leprosy patients. We know that BCG, the vaccine for leprosy is, we tell that if someone is vaccinated with BCG, the chance of leprosy is less. In many case control studies in the endemic areas, endemic countries, it was seen that the prevalence of Hansen's infection in people without BCG vaccination is more than that those with BCG vaccination. So, and as tuberculosis, Bacilli camegori, Mycobacterium leprae, all are that come under that acid fast Mycobacteria group. They confer a cross immunity amongst them. So BCG, it was known that BCG is effective in preventing leprosy, but nowadays BCG is being used to treat difficult leprosy cases also. That is the new thing in, and it is very cost effective, and it is very easy to get also. And another message is that so you get to know that that is a immunotherapy. Definitely it is an immunotherapy because it induces cell-mediated immunity. So immunotherapy reinforces chemotherapy. Chemotherapy is going on with the immunotherapy, so immunotherapy is reinforcing the chemotherapy. So it results in faster and effective clearance of bacilli. By that way, it is decreasing the morbidity. Leprosy is a disease of morbidity. Nobody dies of leprosy, but there is immense morbidity associated with it. So with immunotherapy, the morbidity is decreased. And to assess the cell-mediated immunity, Mantoux test is a simple test. By that, we can assess the immunity. We can assess with the BCG whether Mantoux becomes. In the first case, after 4 doses of BCG, Mantoux become positive. But in the second case, as the antigen load was less than that of first case, with the first one case of BCG vaccine only, the Mantoux turned positive from negative. So leprosy is a disease which attracted attention of many great people, and still now many works are going on in different corners of world. It is a still, though the bacilli was seen, one of the first bacilli to be observed and the first bacilli to be described by Hansen, it is still an enigma. Not everything is known about it because it has such effect on our immune system. And reactions, type 1, type 2 reactions, these are also dependent on the immunity, humoral and cell-mediated. So these two cases are presented keeping that thing in mind. We are showing one photograph where we know Gandhiji was committed for the cause of lepers in Sevagram Wardha. Here he is nursing the leprosy wounds of